This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Well, we're back. It's a crazy time. We are doing a second coronavirus podcast to go over even more literature. I have our special guests back to us who are gracious enough to give up their time. So I'm going to introduce them and we are going to dive right in. We'll do our conflict of interest and we'll get started. The first one is Dr. Megan Culler Freeman, MD, Ph.D. She's currently a senior pediatric infectious disease fellow at the UPMC Children's Hospital Pittsburgh. She completed her MD and Ph.D. degrees at Vanderbilt University, where she earned her Ph.D. studying coronaviruses in the laboratory of Mark Dennison. She has multiple publications in the field and is author of the coronavirus chapter in the most recent edition of Nelson's Textbook of Pediatrics. Her current research interests include pathogenesis and cell biology of RNA viruses and advanced tissue modeling, with a current focus on enterovirus D68, the hypothesized cause of acute flaccid myelitis in children. Megan, thank you for joining us again.
Thanks so much for having me.
The next guest, of course, needs no introduction. Friend of the podcast, been here numerous times. We appreciate his time, Dr. John Williams. Dr. Williams is professor at the University of Pittsburgh Department of Pediatrics, division director for the Division of Pediatric Infectious Diseases, and a director of I4Kids. John, thank you for joining us again.
Tony, always a pleasure.
All right. So let's do our conflict of interest statement so we can dive right in. I will go first and we'll kick it out to Megan and then you, John. I have nothing to disclose.
I also have nothing to disclose.
I serve as a consultant for GlaxoSmithKline on an independent data monitoring committee. I am on the scientific, and I serve on the scientific advisory board of ID Connect, none of which has any relation to the matter under discussion today.
Soaking up all the news everywhere. If you're listening, you're probably at home. I hope you're not anywhere else or maybe in your car driving to work. And we're all working through this. So let's just dive right in. So the first article we're going to discuss, I want to kind of frame this. So the article is, are patients with hypertension and diabetes at risk for COVID-19 infection? This is by Li Fang et al. And it was March 11th, 2020. In Lancet Respiratory Medicine, a reputable journal, and this was a correspondence paper. Now, this was started the whole hullabaloo about NSAIDS and ACE inhibitors and COVID. Before we get to that, in the paper, they actually open, it's like a 1 or 2 page paper. They open it by discussing 3 studies which showed patients with COVID who had severe disease had comorbidity. Some of them we've discussed on our podcast before last time. I want to kind of briefly review them to set the stage. It's also a nice review, and we're going to go in a little bit more detail on some of the clinical symptoms. So the first one is and I'm going to start by apologizing if I mispronounce anybody's name. I'm going to mispronounce people's names, so I'm going to apologize from now. The first one is by Zhebao Yang et al., and the title is Clinical Course and Outcomes of Critically Ill Patients with SARS-CoV-2 or SARS coronavirus 2 pneumonia in Wuhan, China, a single-centered retrospective observational study, also published in Lancet Respiratory Medicine. And basically they took, this was 32 non-survivors from a group of 52 intensive care unit patients who had novel coronavirus, SARS-2. And then 20, they just state that more of them had comorbidity. So 22% had cerebrovascular disease and 22% had diabetes. And these are of the non-survivors. So that's one study, which we've gone over. But the one I want to focus a little bit more time on is this one by Guan et al. in the New England Journal of Medicine, February 28th, 2020, called Clinical Characteristics of Coronavirus Disease in 2019 in China. What they did here was take 1,099 patients who had COVID-19, where they got a lot of information from their chart, literature review, etc. And then they grouped them as severe and non-severe. Now, to group them, they used the American Thoracic Society and the Infectious Disease Society of America's guidelines for how to decide if someone is severe or non-severe with pneumonia. And this is for adults. And there are major and minor criteria for this. So the major criteria are septic shock with vasopressor needs and respiratory failure requiring a mechanical ventilator. The minor criteria are respiratory rate greater than or equal to 30, the PaO2-FiO2 ratio of less than or equal to 250, multi-lobar infiltrates, confusion or disorientation, uremia BUN greater than 20, leukopenia with a white blood cell count less than 4,000, thrombocytopenia with a platelet count less than 100,000, hypothermia, core temp less than 36 degrees Celsius, and hypotension requiring aggressive fluid resuscitation. So the way it works is if you have one major or 3 or more minor criteria, you are defined as severe disease. And that's what this New England Journal of Medicine paper picked as the criteria, which was nice because it's what we use and we know, so that was good. Then one of the things I would like to go over in the paper is the tables. Now, the tables are really good, and one of the things we didn't discuss last time was the symptoms besides cough and fever that people who had COVID-19 have, and is there a difference between severe and non-severe cases? According to this paper on this table 1, the symptoms that they go through are conjunctival congestion, nasal congestion, headache, cough, sore throat, sputum production, fatigue, hemoptysis, shortness of breath, nausea or vomiting, that's one category, diarrhea, another category, myalgias or arthralgia, and chills. And, the most common symptoms were clearly fatigue and cough, and then sputum production is right up there. Cough for both is like 67% for non-severe, 70% for severe. Sputum production, fatigue is 37.8% for non-severe, 39.9% for severe. Sputum production is in the 30s, and the rest kind of fall in there. But there's no difference between the non-severe and severe cases in terms of the symptoms on presentation. So there was no statistically significant or even kind of different differences in the symptoms. And then looking at the coexisting disorders, which is kind of what this paper was based on, they looked at those two groups. Now, of those who were non-severe, about 21% or 194 had any coexisting disorder. Of those patients who were classified as severe, 67 or 38.7% had any coexisting disorder. And John, we've talked about this in the past, but right off the bat, that's not a big number. 38.7% of patients, of this 1,099 patients who had severe pneumonia, had coexisting disorder, which is 61.3% had nothing.
Yeah, what I wish they would have provided, Tony, is a breakdown of, which I don't think they did, coexisting conditions in the entire population versus the older adults. Because we know that even otherwise, adults over 70 have a much higher rate of death. And so for younger adults, this virus is not influenza. But otherwise healthy young adults almost never are hospitalized with influenza unless they have underlying conditions. And my guess here would be that if you divided this into the less than 65 and over 65, that the under 65 would have a higher rate of pre-existing comorbid conditions, and the older adults, just being, sadly, for those of us who are getting older, just being old is in itself a pretty significant risk factor. So, because in this country, we're really not seeing that. If you look at data as of last week out of Seattle, there was not a single death in somebody under 40 in Seattle.
And that's interesting because we're going to get to the MMWR closer to the end, I think, where they didn't do that there either. They didn't break anything down by age, and an MMWR report had no comorbidity. They didn't have any information on comorbidities. So that type of deep or detailed information just at this point isn't out there that I could find.
No, I think that's right, Tony. That's the problem. Is right now the kind of detail that we as providers sort of want to know is how worried am I about my patient, adult or kid who has an underlying condition, who's on a biologic that's immunosuppressive. Even within these disorders like hypertension, diabetes, or asthma, boy, there's a really wide spectrum between, the poorly controlled, brittle type 1 or type 2 diabetic, who we know is at high risk for things like MRSA and influenza and sepsis, versus a very well-controlled diabetic. And the same for hypertension and asthma. So, we'd really like to have that granular detail, but I just have not seen it in any papers. I don't know, Megan, if you've been reading this literature very closely and you're a coronavirologist, I don't know if you've seen more detailed info in any of these.
No, I had been looking specifically for asthma and haven't been able to find anything at all. Just thinking about the most common comorbidity that we see in children and wondering how that might be predictive of how somebody might handle this infection, and really haven't been able to find anything.
Megan, I was looking at the same thing. There was an allergy paper which I don't think we're going to get to, but it was another allergy paper for COVID-19, and they asked patients to self-identify as asthma, and no one on the severe or non-severe side self-identified as asthma at all. But let me ask you, for SARS in 2003, SARS-1, was there this type of phenomenon where patients who had any comorbidities seem to do worse, older patients seem to do worse, or is this specific for SARS-2?
No, that seemed to be similar for SARS-1 as well.
Okay. So, but let me finish this out. So the coexisting disorders in this New England Journal of Medicine paper, they looked at COPD, which surprisingly wasn't high in either group. 0.6% in non-severe, 3.5% in severe. They looked at diabetes, and that was 5.7% or 53 patients in the non-severe, and 28 or 16.2% in the severe. So the diabetics have a higher percentage of having issues. Hypertension, also the same thing, 13.4% in the non-severe, 23.7% in the severe for hypertension. Coronary artery disease, it's 1.8% and 5.8% respectively, non-severe and then severe. And then the rest really didn't change very much. Hepatitis B, cerebrovascular disease, coronary heart disease, cancer, chronic renal disease, and immunodeficiency. There was no one in the severe category with immunodeficiency. So the rest didn't shuffle, but the two that changed significantly were, first of all, diabetes and hypertension. And those were the two that seemed to be over and over again. And for this, back to our paper by Li Fang on hypertension and diabetes, that was one of the major points of their theory, I think, was that once they discussed that hypertension and diabetes are two major risk factors, or two factors that make someone more likely to have severe disease in COVID-19, they began talking about, and Megan, this is where I want your help with this, that SARS-1 and SARS-2 viruses bind to their target cells through the angiotensin converting enzyme 2, which is a receptor expressed on epithelial cells of the lungs, intestine, kidney, and blood. And this was found initially in SARS-1, right?
Yes. So that ACE2 is the receptor that's used for SARS-1, and it's also the receptor used for SARS-2.
And then they state that in patients who have diabetes, who are treated with ACE inhibitors or ARBs, or angiotensin receptor blockers, or hypertensives who are treated with ACE inhibitors or ARBs, those medicines will upregulate the ACE2 receptors. And then also TZDs or thiazidinodes and ibuprofen will also increase the ACE2 receptors. And what their theory is, because those diseases and medications will upregulate ACE2 receptors, that could be the reason why you're seeing more severe cases in COVID-19 in those who have hypertension and diabetes. Did I say that right?
You absolutely did. So I think the key point about this paper is it's a correspondence piece, right? It's an opinions piece. So while this makes a lot of theoretical sense, if you're taking a medication that increases the number of cells that have the receptor that lets the virus inside to replicate, theoretically, you could have worse disease. The problem with this just being an opinions piece is that we don't have data necessarily to support the theory, right? So right now it's just a hypothesis, which is a reasonable one. And I think it's an important one to think about and for it to be out there. But we don't have the data that teases out this person is more at risk because of their underlying health versus this person is more at risk because we know that they have 50% more receptor expression than their counterpart.
And am I right, and John, I want to loop you into this as well, that there are countless examples in science and medicine where someone had a good theory that made sense on paper, and then in practice, when you did the experiments, didn't work?
Yes, many examples of that in science and medicine. Look at, in the field of infectious diseases, for example, let's take sepsis. Right? There have been many trials of things for sepsis, things that blocked LPS, things that blocked toll-like receptors, things that blocked TNF-alpha, et cetera, et cetera. Essentially all of these have failed. Back in the day, sulfa drugs were considered the drug of choice for neonatal sepsis until Dorothy Anderson and colleagues at Columbia University did a study in kids and discovered that not only were sulfa drugs not ideal, sulfa drugs greatly increased the risk of kernicterus in these septic babies through displacement of bilirubin from albumin. So those are just a pediatric example. But yeah, I think what drives this is we've all had the experience of a patient where they have something that we don't have a drug to treat. That's very common in viral infections. As physicians, we all like to do something. Nobody likes to not do anything and to say, well, we don't have anything to do right now. Let's just wait and see. I think that's what drives us. And it's not to say that we should shut the door on potential new drugs. Look, the physicians in China have cared for thousands of patients with COVID-19. And I'm not dismissing what they have said in press conferences like, hey, we really think it works. And they've put it in their national guidelines. But that doesn't mean the data are really there to support it. And I think before we use drugs in an uncontrolled fashion, drugs that have significant side effects and that we have limited quantities of, we should do it in an RCT. So, what's happening now is there are RCTs gearing up and happening in the U.S. using hydroxychloroquine. And many institutions are saying, well, if you have severe hospitalized patients, it's reasonable to consider it. And I think that makes sense as long as somebody's, on a cardiac monitor and they're watching them closely. But what I think there just isn't support for, and it might actually even be bad, is things like people stopping their antihypertensives and getting a hypertensive crisis, or just treating people broadly with hydroxychloroquine. And then that outpatient who wasn't that sick gets an arrhythmia and dies. So I even physicians and scientists have this slightly panicked, rush to things. I think we need to fight against that. And we, especially as physicians, need to set an example for lay people who look to us for guidance. And they're not looking to us to run around like chickens with their heads cut off and say, oh my God, let's use interferon, ribavirin, Kaletra, steroids, and hydroxychloroquine. We can still be thoughtful and judicious in what we do.
And to your point, that paper we just went through caused a whole stir. The French health minister said we should stop ACEs and ARBs and consider not using ibuprofen. And then the WHO had to actually put out a tweet because there was reported that they were saying the same thing, saying that there's just not enough evidence to support not using ibuprofen in patients with COVID-19 or because of COVID-19. But now, since you brought up hydroxychloroquine, let's get to that paper, because that's also been in the news multiple times. Different news stations, the president's talked about it, so everyone's heard about it. So now this paper is hydroxychloroquine and azithromycin as a treatment of COVID-19, results of an open-labeled, non-randomized clinical trial by Philippe Gautret et al. And this was published in the International Journal of Antimicrobial Agents, March 20th, 2020. Now, the last author on this is Dieter Raoult, and he's apparently, and this is what I wanted to ask. I wanted to start out because what was reported was this particular infectious disease specialist is very well known internationally. I'm not an international infectious disease person expert, so is that true? Is he like would you consider him like a colleague of, let's say, Fauci, for instance?
Didier Raoult is a field leader, microbiologist, physician scientist. He is well known for a lot of things. He and his team discovered a class of viruses called giant viruses that infect amoeba. And he has been involved in what some people call paleomicrobiology, like, extracting DNA from the teeth of bodies buried during the Black Plague to do PCR for Yersinia pestis DNA to say, yes, that bacteria really did cause plague. Yeah, I mean, he's an expert on Bartonella infections. And years ago, I emailed him to ask his advice on a difficult case I was dealing with. So he's absolutely an expert.
Okay, good.
But
yes, but why don't we? So then he wrote this paper and then like a hot topic article for the same journal titled "Chloroquine for the 2019 novel coronavirus, SARS coronavirus 2." So what they referenced initially in the paper is a recent paper on the growth of SARS-2 in vitro, and an early clinical trial conducted in COVID-19 Chinese patients showed that chloroquine had a significant effect both in terms of clinical outcome and viral clearance when compared to control groups. They stated that the Chinese experts recommend that patients diagnosed with mild, moderate, and severe cases of coronavirus COVID-19 pneumonia should get chloroquine. They conducted this clinical trial aiming at assessing the effect of hydroxychloroquine on SARS-2 infected patients, and they got the approval by the French Ministry of Health. So what they did was recruited patients in the Marseille Center for the south of France, and patients who were treated were specifically recruited there. And they did controls with patients recruited in Marseille, Nice, and Avignon, and the Brisson Center, I'm sure I'm saying that wrong, also located in the south of France. The inclusion criteria for the study was A, you had to be hospitalized, B, you have to be at least 12 years or older, and then you had to have PCR documented SARS coronavirus 2 carriage in the nasopharyngeal sample at admission, whatever their clinical status. The exclusion criteria was a known allergy to hydroxychloroquine or chloroquine or another known contraindication to treatment with the study drug, like retinopathy or G6PD or QT prolongation. Then breastfeeding and pregnant patients were excluded based on their declaration and pregnancy status. And then patients were seen for enrollment, initial data collection, and treatment on day 0. And again for follow-up during 14 days. Each day, that patient got a physical exam. A nasopharyngeal sample was also collected. And all the patients in the Marseille Center were given 200 milligrams of oral hydroxychloroquine sulfate, TID, for 10 days. Anyone who refused at the Marseille Center or had exclusion criteria became a control. And patients in the other centers didn't get any of the hydroxychloroquine, but they served as controls. Symptomatic treatment with antibiotics as a measure to prevent or treat bacterial superinfection was provided by investigators based on clinical judgment solely. The primary endpoint here was virological clearance at day 6 post-inclusion. And then the secondary outcomes was virological clearance over time during the study period or clinical follow-up with like a body temperature of normal respiratory rate, long hospital stay, etc., and occurrence of any side effects were secondary outcomes. So I'll get to my question. I just want to run through. They did a bunch of stats, which I'll ignore, and just we'll get to that later. The results were they enrolled 36 out of 42 patients, meeting the inclusion criteria in the study. A total of 26 received hydroxychloroquine, and 16 were control patients, so that's the 42. But then 6 were lost to follow-up during the survey, and they gave the reasons why. 3 of the 6 were transferred to the ICU. 1 was transferred on day 2, day 1. 1 was transferred on day 3, and 1 was transferred on day 4. And then they talk about their PCRs. For the first one was positive on day 1. Second one was positive on day 1. The third one, the PCR is negative on day 2. So that was a little odd, because why was the patient in the study if the PCR is negative? I'm not sure. One patient died on day 3 post-inclusion and was PCR negative on day 2. Also a little bit odd. One patient left the hospital on day 3 post-inclusion and was PCR negative on day 1 and 2. 1, 2, 2. And one patient stopped the treatment on day 3 post-inclusion because of nausea and was PCR positive on day 1, 2, and 3. So then they had 36 patients total, 20 with hydroxychloroquine and 16 controls. And then they only reported on those 20. And none of the controls were lost to follow-up. They went through demographics. The mean age was 45.1 years. The patients were, male was 41.7%. The proportion of asymptomatic patients was 16.7%. The patients who had upper respiratory tract infection was 61.1%. Lower respiratory tract, 22.2%. All patients with lower respiratory tract infections had confirmed pneumonia by CAT scan. And then hydroxychloroquine treated patients were older than control patients. So they were 51.2 years on the mean versus 37.3 years for control patients. But there was no other significant difference between treatment and control groups in gender, clinical status, duration of symptoms prior to inclusion. And then they talk about in the hydroxychloroquine patients, 6 got a Z-Pack to prevent bacterial superinfection. And they talk that, then they begin discussing the results. And they talk about the proportion, the effect of hydroxychloroquine on the viral load. And they use this nasopharyngeal PCR as their test of cure. So the proportion of patients that had negative PCR results in the nasopharyngeal samples significantly differed between the treated patients and the control groups on day 3, 4, 5, and 6 days post-inclusion. At day 6, post-inclusion, 70% of the hydroxychloroquine treated patients were virologically cured, which is their term, compared with 12.5% in the control group. Before I get to the Z-Pack with hydroxychloroquine, this idea of virologic cure, my question, and I'll kick it out to Megan first, then you, John, because I want to hear what both of you think of that. Is that a typical way to test effectiveness of a viral treatment for a virus in a clinical study?
So the short answer is no. I think there are a lot of issues with this study, which we'll go into, but one of them is that the endpoint didn't talk at all about how the patient was experiencing symptoms, if they recovered, if they were well enough to go home, if they had been hospitalized. They just talk about the PCR from their nose being negative, which I'm not sure is a super helpful endpoint.
Yeah, the other thing is that actually, the first time I read it through, that's what I thought it was, is a PCR from the nose. And as Megan said, it's hard to know what that means. But reading the methods of the paper, what it says they did is took a nasopharyngeal swab, took that liquid, and cultured it. And then if they saw a cytopathic effect, then they tested that by PCR. So the problem with this is if you're, hydroxychloroquine is very effective in vitro. There's zero question about that. Okay, so it's very clear that hydroxychloroquine and chloroquine are very effective in vitro against COVID-19 and many other viruses. If a patient is taking hydrochloroquine, there's hydrochloroquine in their nasal mucus secretions. So then when you put that into culture, you're putting hydroxychloroquine into culture. So your readout is, does the virus grow? But you're putting drug in there from the patient. This is like doing a blood culture on a patient who's on antibiotics, right? The antibiotics in their blood could inhibit the growth. If you or any of your listeners have ever seen a blood culture bottle and looked at it, you'll see these little beads in the bottom of it. Those are a rosin that absorbs the antibiotic that's in the patient's blood so it doesn't inhibit the bacteria. So these patients were on a virus-inhibiting drug. And the readout in this study is that, does that virus grow in cells in a plate? So, there is, as Megan said, many other flaws, but even their primary readout, I think, is methodologically flawed. And I should note, this paper is what's called a preprint. It's not been peer-reviewed. Many of the COVID-19 papers are preprints. This is valuable because it gets the data out there really quickly so we can all look at it. But I guarantee you, people who review this paper are going to have all the same critiques we will, and before it's formally accepted and published, the authors would have to address a lot of these concerns.
So if I'm following your logic out, if I have a patient who got antibiotic in another hospital and they drew a blood culture after they gave the antibiotic, I can't trust the blood culture because it was treated. It doesn't mean the patient's not sick and doesn't mean they may not get sicker. So is the same logic follow through for this? If the patient is on hydroxychloroquine and it's killing the virus because it's in the medium when they've played it out, it doesn't mean the SARS-2 virus couldn't still be in there causing infection and causing illness.
That's a very good analogy, Tony, is that the drug the patients are on is going to be in those nasal secretions and therefore, potentially in the culture and potentially inhibiting the virus.
All right. So now the rest of they then looked at the patients who got azithromycin, and this was a typical Z-Pack, 500 milligrams on day 1, then 4 days of 250 milligrams with hydroxychloroquine in combo. We've seen in the news, this has been covered over and over again, and they state that the proportion of patients that had negative PCR results in nasopharyngeal swabs was different between the two groups. At day 6 post-inclusion, 100% of patients with azithromycin and hydroxychloroquine were virologically cured, compared with 57.1% in patients with just hydroxychloroquine and 12.5% in the control group. And they said that the drug effect was significantly higher in patients with symptoms of upper and lower respiratory tract infections compared to asymptomatic patients. So does azithromycin have that same kind of effect for culturing a virus?
So, azithromycin, as you know, is an antibiotic. It concentrates intracellularly. There's no reason to expect it to have any direct antiviral effect. Azithromycin has been shown in vitro to have effects on some viruses, although in some of those studies, it was very clearly because the azithromycin was injuring the cells. If you treat cells with the drug in a dish to say, is this drug inhibiting the virus? You have to measure the virus. That's your primary outcome. But you also have to look at the viability, the healthiness of the cells. Viruses are obligatory parasites within cells. And if the cell is not happy, you're going to have less virus. So if you put small amounts of alcohol or bleach on cells, that will have a powerful antiviral effect because it's making the cell sick. And so the studies of azithromycin in vitro, there was a study, for example, of azithromycin having activity against Zika virus. And the investigators looked at the virus amount and the health and the viability of the cells. And the reduction in virus was clearly associated with reduction of health and viability of the cells. So that has no relevance to in vivo what happens in a human. So no, I think the azithromycin part just biologically doesn't really make sense.
Okay. So it's safe to say from what I'm hearing that there were major issues with the study, and we didn't even talk about the small sample size of 20 patients, which seems like a tiny number to base any major assumptions on. So there has to be more done before we can jump to conclusions about hydroxychloroquine with azithromycin.
Well, I think so. There were other, Megan, do you want to touch on some of the other, we both read this study very carefully. There are other flaws.
Yeah, another one that I was just looking at. So they did not pre-select who was to receive azithromycin, right? It was just up to their clinician's discretion. So when you look at the CT value, which is when we're doing the RT-PCR for coronavirus, the lower the CT value, the higher the viral load. So when you look just at their groups, the people who received hydroxychloroquine, on average, I haven't calculated out the math, but there are some people in that group that have 15, 17 incredibly low CT values, which means incredibly high viral loads, compared with the people that got hydroxychloroquine and azithromycin had much higher CT values or lower viral loads, which means that they were probably going to clear that more quickly on their own anyway, independent of treatment. So it's just another area where the study wasn't well controlled.
Yeah, in fact, many of the controls, it says that the treatment group was all at the Marseille Center, but many of the controls, it doesn't say how many, were at other centers in other places. So that would be unacceptable heterogeneity in any clinical study. If you and I, Tony, did a study of, ceftriaxone for meningitis, and we said, we're enrolling our cases here at Children's Hospital of Pittsburgh. And the controls we're going to enroll at Nationwide Children's over in Columbus, Ohio. Like, nobody would ever accept that.
And 6 of the control patients were age 20 or less, and only 1 of the treatment patients was age 20.
This is great because, for me as a hospitalist, you hear on the news from politicians, we have to use this drug, and it's not often you get the time to deep dive and talk about the studies that everyone's basing this off of. And here things are moving so quickly. It's nice to dissect it and say, this isn't the best idea yet. More has to be done.
That's exactly right. I think that's all you can say. But in fact, I would even really temper enthusiasm. I think this paper adds almost nothing because the method for determining the viral load was flawed, and there's the issue that Megan mentioned. And ultimately, do we care about viral load? We do not. In fact, lots of studies for acute viral infections show that medications can reduce the amount of virus but have no impact on clinical outcome because a lot of clinical disease is caused by the immune response. For chronic infections like HIV, viral load correlates extremely well with progression to AIDS. And so controlling viral load is very important. But for acute infections, it's a lot less clear. And ultimately, that's all we care about is the clinical outcome. So I think I'm much more interested to see when the Chinese groups publish their data on, clearly they believe, the experienced physicians there believe that chloroquine or hydroxychloroquine have some benefit. So I'd like to see that actual data so that we can judge for ourselves.
Through social media, we've learned that there's been a run on hydroxychloroquine?
It's hydroxychloroquine. I keep getting that wrong too. These aren't drugs I use much, and we don't use a lot in ID. But
there's been a run on it. Pharmacists have been posting that physicians are prescribing them, and they're running out for people who actually need them. So this is good to get out there that we can just temper our excitement until more stuff comes out and stop prescribing hydroxychloroquine unless you're being guided by an infectious disease specialist in a hospital with a severe patient and it's deemed at that point a good idea.
That's exactly right. I think, you're hearing about physicians hoarding it for themselves. I think that's completely unethical. People, we have sworn Hippocratic oaths. For some of us, it was a long time ago in medical school, but we swore those oaths. And if we're hoarding medicine that we don't need and taking it away from patients with lupus or rheumatoid arthritis who do need it, that's just flat out wrong and unethical, period.
I think the other thing to bring up about hydroxychloroquine is, as a infectious disease community, we've been disappointed in its use for other acute viral infections before, despite promising data in cells. So chikungunya virus is an example. When we actually looked at hydroxychloroquine in patients with chikungunya virus, they tended to have worse outcomes than patients that didn't get that drug. So in some of these instances, we might even be doing harm by using these drugs before we really have good data about them.
Thank you for that. Now we're not going to cover everything I wanted to cover. There's just no way. But let's get to the pediatrics articles. Everyone's talking about it on our hospital medicine listserv and everywhere else. And this is epidemiological characteristics of 2,143 pediatric patients with 2019 coronavirus disease in China. This is by Dong et al., Pediatrics 2020. Now, this was a retrospective study on the epidemiological characteristics of the 2,143 pediatric patients with COVID-19. And children, they defined as someone less than 18 years of age, just so we're all aware. And then how were the cases diagnosed? So initially, diagnosis was based on clinical manifestations and exposure history. Suspected cases were identified if the child had two of the following: fever or respiratory symptoms or digestive symptoms of vomiting or diarrhea or fatigue, and then labs of a white blood cell which is normal or decreased, or a decreased lymphocyte count or elevated CRP, and an abnormal x-ray. So two of those three things they had to have. So right off the bat, the first thing that comes to mind, and they don't go through this in the paper, which is a little bit disappointing, the vomiting and diarrhea. When we looked at the adult literature, and this is one of the things that the first thing I thought of is the old saying, kids are not little adults. The adult literature showed that less than 5% or less than adults had vomiting or diarrhea with SARS-2 or COVID-19. Here they're using it as a diagnostic criteria, which means it's got to be a higher percentage in kids. Am I correct?
Yeah, I'm a little skeptical. I just, when we look, I've done a lot of respiratory virus epidemiology studies where we, analyze hundreds or even thousands of kids with human metapneumovirus, influenza, RSV, et cetera, et cetera. And I've been, engaged with reviewing data from drug or vaccine trials where you have a placebo group. So these are kids that aren't having any kind of experimental vaccine or drug treatment. And basically, if you pick a 2-week period, about 10 to 20% of all kids are going to have some kind of GI symptoms, vomiting and or diarrhea in that time, especially younger kids. So I'm not saying that the virus may not definitively cause those symptoms, but that's, there's no control group here. There are not kids in the hospital for other reasons or kids with other viruses. I suspect if we had those, we might see similar rates of the gastroenteritis. And using that for a selection criterion, we might be missing some of the kids. Megan, what do you think about this coronavirus or others causing a lot of gastrointestinal disease?
It's a described syndrome for all of the newly emergent coronaviruses, SARS, MERS, and SARS-2, but it's never a predominant feature.
So then going further, they said suspected cases who met any one of the following criteria was defined as confirmed cases. So nasal and pharyngeal swab specimens or blood samples tested positive for 2019 novel coronavirus nucleic acid using real-time reverse transcriptase polymerase chain reaction assay. Genetic sequencing of respiratory tract or blood samples is highly homologous with 2019 novel coronavirus. Then they did a severity scale. So severity of COVID-19 of the patient based on clinical features in lab testing and chest x-ray, including asymptomatic, then used mild, moderate, severe, and critical. Now here the descriptions were not the most clear. So asymptomatic was clear. That was without any clinical symptoms and signs, and the chest imaging is normal, but the nucleic acid test for 2019 COVID-19 is positive. Then mild is symptoms of acute URI, including fever, fatigue, myalgia, cough, sore throat, runny nose, and sneezing. Physical exam will show congestion of the pharynx and no auscultatory abnormalities of the lungs. Some cases may have no fever or only have digestive symptoms such as nausea, vomiting, abdominal pain, and diarrhea. That's mild. And then moderate, I even wrote when I wrote it out, this is odd, with pneumonia, frequent fever and cough, mostly dry cough, then followed by productive cough. Some may have wheezing, but no obvious hypoxemia such as shortness of breath, and lungs on auscultation can hear sputum or wet or dry snoring, which I think is their transmitted upper airway sounds. And some may have no clinical signs and symptoms, but chest CT shows lung lesions, which are subclinical. So what this meant to me was that as part of getting this outbreak under control, they just CAT scanned every pediatric patient who came in with any symptoms, looking for what was going on. That was a little odd, but then their description just sounds like a kid who's sick but may not even be hospital sick. Do you agree with that? We'll go different. We'll start with Megan this time. Do you agree with that, Megan?
Yeah, I agree with that. I was also amazed by the number of CTs it seems that people are getting in these studies, and also some of the ones that we had reviewed of adults.
John?
Yeah, I agree too. It's the definitions are a little vague, and I think part of the problem is, right? They say these data sets were extracted from the electronic master database of the Chinese CDC. I mean, these are good data. Okay,
Yeah.
Not criticizing them, but one thing that's missing anywhere in the paper is how many of these kids were hospitalized.
Yeah.
To me, severe is hospitalized, although even there, 2% of otherwise healthy term infants in America are hospitalized with RSV. They're in for a couple of days wheezing and then they're gone. Is that severe? I guess so, but in the grand scheme of things, it's not that severe. So I agree. It made it a little difficult to know here. The CT, early on in the outbreak, especially in adults, there were a whole bunch of papers about CT for COVID-19. And many of these papers were suggesting that the CT was very specific for COVID-19. And I just don't buy it at all. I mean, any of us, both of you, like we've had patients with some kind of viral pneumonia, flu, metapneumovirus, RSV, whatever, and they get a chest CT and it's never normal. And it has these things like ground glass opacities. And, I think the CT thing really took off in China. I don't know, maybe price is no object and they like to get CTs on lots of people. But I agree. It was very unusual because I suspect that very, very, very few kids here with COVID-19, like RSV and flu, are getting CTs. It's kind of surprising.
Now, for the severe and critical definition, severe, they state that the early respiratory symptoms like fever and cough may be accompanied by GI symptoms such as diarrhea, and the disease usually progresses around 1 week, and dyspnea will occur with central cyanosis. O2 sats are less than 92% with other hypoxia manifestations. That's severe. That sounds like a hospitalized patient. Then critical, our children can quickly progress to ARDS, or respiratory failure. They also have shock, encephalopathy, myocardial injury, or heart failure, coagulation dysfunction, and AKI. These are very sick kids. And organic dysfunction can be life-threatening. And then they had both lab-confirmed and suspected cases included in this analysis. They used the chi-square Fisher-Exact test for categorical variables and the Mann-Whitney U test for median values of non-normal distributed variables. And the results, by February 8th, 2020, they had 2,143 patients were reported to the Chinese CDC, 731 were lab-confirmed, and 1,412, or 65.9%, were suspected. The median age of all the patients were 7 years old, but their interquartile range was 2 to 13 years old. There was no statistically significant difference between males or females. And for severity, asymptomatic was about 4.4%, or 94 kids. Mild was at 1,091 patients, or 50.9%. And then moderate is 831 patients, or 38.8%. Now, these together accounted for 94.1% of all cases. So over 94% of the kids had what may be symptoms that wouldn't even require hospitalization. About half of these patients were from the Hubei province. Another 18.5% of the cases were from provinces which bordered Hubei. And young children, they said particularly infants, were vulnerable to 2019 novel coronavirus infection. And here's what the breakdown was. Looking at the age ranges, so less than 1 year old, 10.6 of the total patients who were severe and critical, that's 379 kids we're looking at, of the original 2,100. Of that 379, 40 of them were less than a year old that were considered severe. That's about 10.6% of the severe cases and critical cases were less than 1 year old. And that's by far the biggest group. So then 7.3% were 1 to 5 year olds who were in that category. 4.2% of the total are 6 to 10 year olds, or 22 to 6 to 10 year olds. 17, 11 to 15 year olds. 10 greater than 16 year olds. So the biggest group is the infants less than a year old. And then they had the one death from the Hubei province on February 7th, a 14-year-old male. I think they had a second one since then, but still only 2. And there were more patients in the early stages at the epidemic, then a gradual and steady decrease. between mid-January and early February 1st, there was a big increase in the number of pediatric patients, then a decline since early February. And that may have been as their testing ramped up. They just saw more kids. And then, interestingly, in the severe cases for all age ranges, 94 came from the suspected COVID category and 18 came from the confirmed. So the majority of the severe cases were suspected. That was a statistically significant difference. And we don't have a lot of information on any underlying disorders which could predispose those child to severe infections, like immunocompromised, chronic cardiac or pulmonary conditions. And we don't know about co-infection. So, had they done like a respiratory virus panel on everybody, and we found out that all the severe kids who were infants also had RSV or flu, that may have told us a little bit more, human metapneumovirus. That would be a little more helpful. So to me, it didn't help all that much. And again, with a 6 to 10-year-old group, the suspected cases were also statistically significantly different than the confirmed of those severe kids. So am I right in that it tells us information, it gives us stuff, but it's lacking?
Yeah, for me, this paper, what I found most useful was the confirmed column, because I agree exactly what you said. Suspected, those are kids who weren't tested at all, understandably, given resources and the number of cases they were dealing with. But in fact, flu A was circulating at the same time, just like it has been here, and RSV. So, even in the midst of massive epidemic, okay, like let's take flu. And we all know, we see in our hospitals every year, flu season, and you get to a point where it's a huge peak of flu, and you feel like, oh my God, every kid I see has flu. Even at its peak, it's almost never more than 30% that are flu positive, which means that even during the absolute peak of flu season, most of the kids that we see as doctors have something else besides flu. So I think that's suspected. Sure, there was a ton of COVID around, but there was also a ton of flu and RSV. So I think that suspected column is not interpretable. And I personally focused on the confirmed column.
Megan, I have a specific question I want to ask you based on your expertise in SARS-1. One of the things they talk about in this paper is it may be that we talked about the ACE2 receptors, that the ACE2 receptors in children is less mature, and then the binding ability is less potent, I guess, and that's why kids get less of this COVID-19. Do you know, was the same true in SARS-1 in 2003? Were kids less affected? Could this be a real thing?
Yeah, so I think that is probably one of the best hypotheses that I've heard for why kids have less severe disease. We saw a similar pattern with SARS-1 in that most children were spared, or if they were infected, they had mild disease. I have tried to look into specifically ACE2 receptor expression in kids versus adults and haven't been able to find much out, but I think it's a great hypothesis either based on pure number of cells that express the receptor or, as you were saying, some kind of difference in the maturity of the receptor.
Okay. Now, we're running very short on time, so the only thing we can still cover at this point, and I'll rush through it, is the MMWR on March 18th of this year, severe outcomes among patients with coronavirus disease 2019 COVID-19 in the USA. This was reported review. This was a case of all the people in the United States from February 12th to March 16th who had severe disease, hospitalization, admissions, ICU, and death, and were analyzed by age group. And as of March 16th, there was a total of 4,226 COVID-19 cases in the U.S., which were reported to the CDC, with multiple cases reported among older adults living in long-term care facilities. There was hospitalizations in 45% of the cases, 53% of them had ICU admissions, and 80% of the deaths were associated with COVID-19 were among adults age 65 or older. And the highest percentage of severe outcomes amongst persons aged 85 and above. At the time this was written, there were no ICU admissions or deaths reported among anyone less than or equal to 19 years old. That has since changed. For this, they excluded anyone who repatriated to the U.S. from Wuhan, China, or Japan, and those who came from the cruise ships were excluded from this study. There was no data in this study on underlying health conditions available for the report, and I'm just going to break down the results very quickly. Of the 4,226 patients, only 2,449 actually had a known age. So of those, 6% were older than 85 or older, 25% were between 65 years old and 84 years old, 18% were 55 to 64 years of age, another 18% were 45 to 54 years of age, 29% were 20 to 44 years old, 5% were 0 to 19. Of the 508, or 12% of the total, known to have been hospitalized, 2 to 3% were less than 19 years of age, 20% were 20 to 44, which was the second biggest number, 18% were 45 to 54, 17% were 55 to 64 years of age, 36% were 65 to 84 years old, and 9% were greater than 85 or older in terms of age. And among the 121 known to be admitted to the ICU of the initial group, those in the ICU, 0% were less than 19, 12% were 20 to 44 years old. Now that was a big number, I thought. 20 to 44 years of age, 12%. 36% were 45 to 64 years old. 46% were 65 to 84 years old. And again, only 7% were equal to or greater than 85 years of age. Now, the paper, this paper has figure 2, which was really nice. It was a graphic description of what I just read. It was clear and it was concise and it made sense. The most hospitalizations are in the 65 to 74-year-old group. But number 2 for hospitalizations in terms of total numbers were the 20 to 44 years old group. But that 20 to 44-year-old group had the third lowest ICU admissions. So the numbers are kind of all over the place. And then in our discussion, which I thought was great, they said that the data was similar to what they saw in China, and then the preliminary data shows that there's severe illness leading to hospitalization, including ICU admission, can occur adults of any age with COVID-19. In the U.S., they said there's about 49 million people aged 65 or older. And then they talk about this being an epidemiologic paper, and there are 5 limitations. So their number 1 was the data on age and outcomes, including hospitalizations, ICU admissions, and death. It was missing for like half the patients that they could have had. There was more time for follow-up needed for active cases, see what happens. Do more people die, or do they get better for those that are still active? And the initial approach to testing, which we've all been now familiar with if you're listening, was travel history or people with more severe disease. So then you miss the community-acquired asymptomatic mild cases, which we didn't found. Data on other risk factors like underlying health conditions was not there. And then limited testing to date underscores the importance of ongoing surveillance. So the only thing I got from this paper was that this disease really can hit anyone of any age. And that's about all I could get from this. Am I being too hard on it?
No, I think that's the most important takeaway. You know, when we see the news about college students still going on spring break and being in beaches, it really hits home that they think that this is a disease that can't affect them. And I think these numbers really point out nicely that just because you're in the 20 to 40 age group doesn't mean that you can't get hospitalized or even land in the ICU with this disease.
Yeah, I totally agree with that. I think the one problem with this, and I just wish they had done it a little differently to make the table 2 lines or 3 lines longer. So everything from 45 up are in 10-year blocks. 20 to 44, that's 2.5 rows of the table because it's 24 years instead of 10 years. And then 0 to 19, okay, maybe to everybody but pediatricians and parents, they think of that as quote unquote kids. But for us, there's a big difference between 0 to 9 and 10 to 19. So I wish those data had been broken out a little bit more to know, are those hospitalizations and ICU admissions and case fatalities, if 4% of 20-year-olds with COVID-19 were getting in the ICU, that would be a big deal. I'm just guessing that 4% upper limit would be 40-plus-year-olds with underlying conditions. That's my guess.
And I think this underscores that there's such a panic around this right now. I mean, and it's a big health concern that any information is being sopped up. It's being put on social media. People are talking about it on TV. So we just have to be a little bit more careful as physicians in how we digest the information to disseminate it out to the public.
Oh, I totally agree. One of my friends on an ID group chat that we're on said this is a virus that appears to remove your ability to think critically, even if you aren't infected with the virus.
Well, that's all the time I have. Let me just thank you, John and Megan. I really appreciate your time on this. I don't know if we'll do a third, but I really appreciate your generosity with your time. Thank you both so much.
Happy to help, Tony.
Anytime.
And then for those of you listening, before I do my usual sign off, there's a lot going on. There's a shortage of supplies everywhere. Everybody's very worried. Stay safe. My thoughts and prayers will be with all of you. We will get through this. Just keep yourself safe. Keep your family safe. Do your best. And I appreciate all the work, all my colleagues in medicine, whether you're a nurse, a PA, a nurse practitioner, a physician, putting yourselves out there to take care of patients. We all do it every day. So I want to thank you all. I'll be out there with you. I'm on for a 13-day stretch starting on Saturday. So good luck to everybody. I hope to see you all soon. Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. It takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.